Hello, everybody. My name is Michelle Jones, and I would love to welcome you to today's workshop with Dr. Michelle Tollefson. Thank
Oh,
you.
it's so great to be here with you today. Thank you for the invitation.
Yeah, and we're so excited to have you here with us. So I'm excited to be here with Dr. Tollefson, but I'm also thrilled to have you, each and every one of you, here with us today. So if you haven't found the chat yet, I encourage you to go ahead and say hello, tell us where you're from, maybe tell us why you're excited for today's workshop. I know I see Laura has already found the chat. So before we move on and I turn things over to Dr. Tollefson, I would love to tell you some of the things about her. And so I'm going to go ahead and read a quick bio. Dr. Tollefson is a prominent figure in women's lifestyle medicine. Based in Colorado, she holds, my screen just moved away. She holds board certifications in lifestyle medicine and obstetrics and gynecology. She serves as a professor in the health professions department at Metropolitan State University of Denver and is the lead faculty for the Blue Zones and American College of Lifestyle Medicine certification for physicians and health professionals. Dr. Tollefson serves on the executive board of the nonprofit Paving the Path to Wellness. Her editorial leadership includes the textbook Improving Women's Health Across the Lifespan and co-authorship of Paving a Woman's Path Through Menopause and Beyond, alongside Drs. Frades and Commander. Dr. Tollefson was one of the first physicians ever trained as a health and wellness coach and is renowned internationally as a speaker and women's health consultant. A dedicated mother to 3 children, she is also a breast cancer survivor, an advocate for thriving through adversity. Specializing in evidence-based practices, Dr. Tollefson empowers women to thrive during and after menopause. Healthy lifestyle strategies such as nutrition, physical activity, stress management, sleep hygiene, and fostering social connections. And again, Dr. Tollefson, thank you for being here. We are so excited. I'm going to go ahead and put up the slides. So I'm turning things over to you at this time.
Wonderful. Thank you so much. I am so excited to be here with all of you today. It looks like we have about 125 people joining. Yay! So I am so thrilled that I get this chance to speak with you about one of my very favorite subjects, taking charge of your health. We'll talk about annual exams, menopause, and what to expect. So I am trained as an obstetrician gynecologist. This is me in residency training, and I'm second from the right. We spent a lot of time learning how to do surgical procedures, prescribe medications, but there wasn't a lot of focus on healthy lifestyle behaviors, nor was there a huge focus on menopause. Some, but not a lot. So I was out in private practice and became a professor at our university and was busy learning all that I could about lifestyle medicine and women's health. And menopause was pretty far from my mind. Menopause seemed like it was in the distant future until on a routine screening mammogram, a 2-centimeter mass was found invading my chest wall. Going through chemotherapy and 7 surgeries, I went into premature menopause, had my ovaries removed, and I had forever entered the menopause club. And it wasn't a gradual change into menopause, it was a menopause crash. So going through this experience taught me that if I felt alone going through this and I felt like I was having a hard time finding enough information, evidence-based information, or I was having kind of a hard time looking through some of the different messages pointing me here and there, I thought, oh my goodness, if I, with all of my gynecologic knowledge, was still feeling like there wasn't adequate information, that so many other women were likely feeling the same. So I want you to know, if you're feeling confused about menopause, if you're feeling like you just want more information, if you feel like you're not sure if you are in menopause, out of menopause, perimenopause, the transition, what is it? You are not alone. I am here to help. We're so thankful that Ardmore has put this time together for us so that we can become more knowledgeable and empowered. We know that according to the State of Menopause survey, that about 94% of all American women feel unprepared for the symptoms. Over 9 out of 10 women feel that more education is needed. And although 6 out of 10 women seek treatment, only about 25% of women actually get the treatment that they say that they need. So there is a huge need for more training among health professionals and also for more evidence-based information. And so by the time you leave today's session, hopefully I will have given you a lot of evidence-based information, hopefully decrease the fear that sometimes comes around talking about menopause, help to clear up some of the misinformation, and we will definitely tackle that lack of knowledge that so many people experience. So let's start about talking about menopause and how we can think of it in order to optimize our health. The menopause transition is a window of vulnerability. When we go from higher levels of estrogen and then we have that estrogen that decreases, it's a time when our health it's vulnerable to changes that don't always lead us to positive outcomes. And so anyone who tells you that menopause will be a breeze for everyone or only joyful times of dancing through fields, I think we need to be realistic. Menopause is often challenging for many people. So we have this window of vulnerability. However, the really exciting thing is that menopause is also a window of opportunity. That transition, that time when a woman goes through the menopausal transition is really a window of opportunity for us to take charge of our health and to decide if we're on the right path as far as our health trajectory. And if we're not, to make some changes that can help us long term. So today I want you to think about how you can take charge of your health trajectory, whether you are somebody who is already extremely healthy, whether you feel like you have all the right information, that's great. Hopefully this will affirm you to continue going in the direction you're going. And if you're someone who maybe needs to make some changes or tweak some things, hopefully this will give you that boost that you need in order to really take charge of your health trajectory, because you truly have so much power. Genes are not our fate, and we know now that our healthy lifestyle behaviors, especially nutrition, eating a whole food, plant predominant diet, getting adequate physical activity and stress management and sleep and social connection, that those are incredibly powerful to our health and longevity. So today I want to first talk about some of the different symptoms that many women experience as they go through that menopause transition. I also want to talk a little bit about what a typical physician or health professional visit might be like for somebody who is approaching or is going through menopause. I want to talk about some different medication options, including hormone therapy, however, not limited to hormone therapy. So I'll talk about a variety of prescription medications that are available to help with some of the menopausal symptoms that are options. And then last, but definitely not least, I want to talk about healthy lifestyle options that can help us with so many of the menopause symptoms and optimizing our health. So first of all, this seems like it's such basic knowledge, but I think it's important to highlight that menopause is natural. It is normal. It is not a medical condition that must be treated, and that you have options. I think so often in our society that menopause has kind of gotten the reputation of it's like a disease that everybody needs to be treated. We need to give everybody medication, and it's kind of like vilified. But on the other hand, I think there's people who have really been struggling with menopause symptoms where they've maybe been told by providers or by society, oh, it's part of life, it's natural and normal, so why are you even complaining? I would say we don't want either of those extremes. We want to come back to remembering that the menopause transition is something every woman will go through who has ovaries if she's fortunate to live long enough. It's natural, it's normal, but we live in a time when there are tremendous options. And I believe you have the right to be empowered about to be knowledgeable about your options so that you can have informed conversations with your health provider. One of the things that makes menopause so tricky, and maybe why so many providers maybe don't want to fully engage in menopause, is that it's unique. It is tricky. The menopause transition experience is unique to each woman, just like our fingerprint is unique. Our experience is unique. There's some women who have absolutely no symptoms. We know about 80% of all women will have hot flashes or night sweats. And there's a variety of other symptoms too. And so every woman is different in the symptoms she experiences, the age that she starts experiencing these symptoms. Some symptoms might be really, really bothersome to some women where it's negatively impacting their quality of life, whereas another woman might have some mild hot flashes that don't bother her at all. And she would think, why would I ever think of treatment, right? So that experience is unique to each woman. And that's why we really need to know our options as far as what we can do. So a little bit of science talking about the hormones. I'm sure you've heard of estrogen, which is in the orange on this graph, and progesterone, which is blue. And if you look at this graph, Prior to menopause, the levels are going up and down with a woman's reproductive cycles, with menstruation. We see that the levels of estrogen are going up and down and up and down, and that's what helps us to ovulate, release that egg every month. So we are seeing a fluctuation. Every month, as those eggs are released from the ovary, we lose more and more of our eggs. We are born with all of the eggs we will ever have. There's usually about 2 million or so at birth. And by the time we get to the menopause transition, there aren't very many left. And so the hormones from our brain are trying to tell our ovaries to release those eggs, but they aren't necessarily releasing an egg every month. And so that's where we start to see those huge fluctuations in hormone levels. This is what I like to call the hormone roller coaster. And this is for someone who goes through natural menopause. So for example, for me with chemotherapy and having my ovaries removed surgically because of the type of cancer I had, it was a sharp drop, right? It was not a transition. It was a menopause crash or a hormonal crash. But for most people who go through menopause naturally, not because of medication like chemotherapy or surgery, you'll see this up and down, up and down. And this is what we call the menopause transition. Now, this is when a woman is still having menstrual periods. And so a lot of women are like, well, I'm only in my 40s, or I'm still having periods. And so these couldn't be menopause symptoms. However, we know that most women begin having menopausal symptoms or menopause transition symptoms in their 40s. And so for some women, that means late 30s. For some women, that means not until they're 50. But we have this large area of variation where women are experiencing those huge hormonal changes and symptoms. So if you're asking now, like, then what is menopause? Menopause is actually just one day. We use it to kind of talk about the whole period around it, but menopause is just one day. And it's that one day when you can look back and say, I have not had a period for 1 year. So for somebody for natural menopause, if somebody hasn't had a period for 8 months, they haven't actually reached menopause. And if they have another period, then they have to start that year-long clock again. But regardless, that one day isn't as important as knowing that women can experience symptoms around this entire time. The average age of the menopause transition in women in the United States is 51 to 52 years old. But women typically have symptoms of a menopause transition starting several years before, like 4 to 8 years before. But once again, every woman is different. Some people will start to experience symptoms 10 years before. It's really different for each woman. So why is estrogen so important? Many women know that estrogen is important in order to get pregnant and in order to have menstrual cycles. And that is true. And in addition, almost every single tissue within our bodies, all the different, like our brain and our bones and our muscles, have estrogen receptors. And so when those estrogen levels start going up and down and up and down, it is not just affecting the ovaries, not just affecting the uterus, it is affecting all parts of our body. We know that during the menopause transition, that's where we have that window of vulnerability. So we want to be thinking of brain health. We have many estrogen receptors in our brain. And so what do we need to do in order to optimize our brain health and heart health? We have estrogen receptors in our heart muscle health, skeletal muscle throughout our body, bone health, sleep health, metabolism. So we need to be thinking of all of these things because our estrogen levels, when they were more stable prior to menopause, that help to protect these areas. And so it's not that healthy lifestyle behaviors weren't important before then, but we had a little bit of an extra buffer with that estrogen. As we go through the menopause transition, those health behaviors, that whole food, plant-based, or eating a bunch of healthy foods that are minimally processed, rich in plants, eating fewer ultra-processed foods, getting enough physical activity and stress management and sleep, all of those different things become even more important. Hot flashes, as I mentioned before, about 80% of all women will have hot flashes. On average, they last about 7 to 10 years, but some women never have a hot flash and other people have them for decades. For some women, they can just be a nuisance. Maybe they have a few that are very, very mild. And for other women, they can significantly negatively impact their quality of life. We know that hot flashes are associated with insomnia. So when they occur at night, they're called night sweats. We know that they go along often with irritability, sometimes depressive symptoms. They can go along with brain fog. And then we also see women who have real severe hot flashes have a higher risk of heart disease that we're trying to fully kind of piece together the reasons why. With hot flashes, we know that there are changes in brain hormones and the receptors. And so women become really, really sensitive to those external temperature changes. And a hot flash is just our body's way of vasodilating or dilating our blood vessels to help release that heat. Also, women have a variety of triggers. For some women, if they eat really spicy foods, they may have a hot flash. For some women, it's getting extra stressed and they'll have a hot flash. So there are different triggers. But when we think about hot flashes, you can see prior to menopause, we have that pink zone where that's what I call the thermoneutral zone, or what's called the thermoneutral zone. And your temperature can fluctuate within that, and you still feel very comfortable. I'm in the thermoneutral zone right now. I'm not having a hot flash. I'm not shivering. But what happens with the menopause transition, when we start to see those fluctuations of hormone levels up and down, is that the thermoneutral zone typically shrinks. So you can still be comfortable. However, if I were to increase my temperature a little bit, I might have a hot flash, or if I were to decrease it, I may have shivering. And so you're able to still stay comfortable, but it's that there's that more narrow range. We know that with the menopause transition, that most women will have irregular periods. Most people don't have regular periods and then it just stops for forever. Many women will have some periods that become kind of irregular. Many women experience fatigue, and part of that is probably due to night sweats, maybe disrupting sleep, but we think that there are some other hormonal changes that lead to fatigue for so many women. We know prior to menopause, fatigue is fairly low. During the menopause transition, it's higher, and post-menopause, it's very high, which is another reason why eating an abundance of healthy foods and physical activity is so important. We also see that many women experience weight gain. It's not inevitable, not all women, but I think we need to be compassionate to ourselves. As estrogen decreases, it changes our blood glucose level so that our blood glucose is often a little bit higher. It contributes to some insulin resistance. It also makes it harder to maintain our lean muscle mass, so our bone mass and our muscle mass. And so many women during the menopause transition will see extra visceral fat, or the fat that accumulates around the organs, like around in our abdomen. And so we see often women will say, I'm eating the same things, I'm exercising just like I was, but I seem to be gaining weight, especially around my middle. And so I think it's important to be compassionate and know that as hormone levels change, that we often see this, but it's not inevitable. That's where eating our more way of eating, or full plate living, that's where eating in that way helps to decrease visceral fat and can help to ameliorate that weight gain. And it's really important for our health. We also know that many people experience skin and hair changes, dryness. We see vaginal dryness in over half of all women, where sometimes intercourse can become uncomfortable. We know a lot of women will have aches and pains. They're trying to call this the musculoskeletal syndrome of menopause, because so many women have aches and pains, and many women will get headaches. Now, once again, not all women. So this is where it becomes kind of tricky during menopause, or during the menopause transition, and because it might be that you're having some aches and pains due to the menopause transition. However, it's important not to just say, oh, well, it's definitely due to menopause, and to kind of blow that off. Or the same thing with headaches. It might be that you're having more headaches because of the menopause transition. However, it's important to talk to your healthcare provider to make sure that you can rule out other things and get help. We also see that during the menopause transition, we see a lot of women experience mood swings, or what we call mood lability, as hormone levels go up and down. You can imagine that mood can often be very variable as well. We see an increase in irritability, anxiety and sadness, emotional fatigue, brain fog, decreased confidence, and decreased sex drive. These are things that are common. They are not things that everyone experiences. So after going through all of these possible symptoms, knowing that most women do not experience all of them, and knowing that a healthy lifestyle helps to decrease these symptoms in many, but not all women, it's important to know that you need to have that relationship with a healthcare provider who can help walk alongside you during the menopause transition. So many women will say, am I too young to discuss menopause? I'm only in my 30s. And I would say you are never too young to discuss menopause. I think it's important for you to start having conversations about the menopause transition, whether you're in your 30s and are thinking about it in the future, whether you're in your 40s, maybe having some symptoms now, whether you are 50 and you stopped having periods years ago. I think it's important to discuss where you're at in that menopause transition with a trusted health provider. I also recommend having annual exams. And of course, when should I have an annual exam? Well, hopefully you're having them yearly, and then coming in for other problems or concerns at other times. And so an annual exam, if you haven't had one in over a year, I'd encourage you to call up your health provider and ask if you can get scheduled for an annual exam so you can go in there and discuss any symptoms, any concerns, or just get checked out. And if you've had an annual exam recently and you still have some questions about menopause, I'd encourage you to call and make another appointment and to go on in. You know, I often get asked, who should I see? Should I see a gynecologist like you? Should I see somebody with special certification in menopause? Should I see a primary care doctor? Should I see my nurse practitioner or a PA? I would say start with your primary care provider. If you have a primary care provider, talk with them and see if they're comfortable having a conversation. If you're interested in hormone therapy, are they comfortable with having a conversation about risks and benefits? Are they somebody who prescribes it or maybe not? And if they're not someone who feels comfortable having a conversation about menopause or caring for your menopausal needs as you go through that transition, then I would encourage you to ask them if they have any references in the area. Many gynecologists they have extra training in only women's health. And so many gynecologists feel very comfortable with helping women through that change, but there are many primary care doctors, such as internal medicine doctors, family medicine doctors, that are very comfortable as well. So it really depends on the individual practitioner, and nurse practitioners who are great at helping women through the transition, certified nurse midwives. So I would say check in with your primary care doctor. When you go in for an annual exam, there's a whole list of different things that need to be done. Insurance requires some different things happen. And so you'll get asked questions that help to screen for depression and fall risk. So you'll go through a lot of different questions, and they'll want to know what problems you're having or if you have any concerns. And so this is when you can let them know, I've been noticing that my skin is more dry. I've been noticing that I am getting some hot flashes and then my heart beats fast after them. Is that normal? But you should be able to ask those questions. During an annual exam, you'll probably have some type of physical exam, though it's not always necessarily a pelvic exam of the female genitalia. That's not always done during an annual exam. I get asked by women how they should prepare. And so I would say that you're always preparing for your next exam with your healthcare provider. I recommend taking notes and bringing questions. And so I am a fan of always having a notebook or something with you where you can take notes. And so if you're noticing, I've been noticing this going on, or this is bothering me, I would say take notes and kind of investigate what's going on. And then if you have questions, often healthcare providers are so pressed for time that women say, I feel rushed. I had my questions and then I got in there and then the medical assistant was asking me questions and the doctor was asking me questions. And before I knew it, they were gone. And I never had a chance to ask my questions. So I recommend bringing your questions bring that notebook so that you can make sure that you get answers to your questions. And listen to your body. If you're like, something doesn't feel right, I feel like I need to have this checked out, don't delay. Reach out and get it checked out. I also recommend that if you're somebody who has not gone through menopause, if you're somebody who is still having periods, that you track them. And there are various apps that you can use to track your periods if you want to, or you can use an old-fashioned paper calendar or a calendar on your phone. But it's nice when you go in to see your healthcare provider, if you can let them know, my periods have been, maybe they used to be about every 30 days and now they're about every 35 days, or, I skipped a period and then I had another one and it was a little heavier. It's nice if you can be able to relay to your healthcare provider what your periods have been like about how long between the start of one and the start of another, about how many days of bleeding. Is it heavier, more clots than it used to be? Is it lighter, more spotting? And then be ready to have that conversation. The provider who you're working with, whether they're a doctor or a nurse practitioner, a PA, certified nurse midwife, they should all be open to dialoguing with you about menopause. But realize that there are some providers who have very, very, very little training, and they may not have the expertise in order to be your guide during that time. It used to be called North American Menopause Society. Now I believe it's just the Menopause Society, but there's a whole directory of physicians and other healthcare providers who have done an extra test or training in menopause. There are many GYNs, though, who have not done that test because they say, I already had all that training in residency, but the NAMS directory can be a good resource for you if you're looking for, if your healthcare provider says, I don't really feel comfortable with that, and you want to talk to somebody more about menopause management. The exam is based on your symptoms, it's based on your age, it's based on your history. It's based on when your last pelvic exam was. Have you had a pap smear in the last few years? If it has always been normal, and they may have you wait. So it's based on a lot of different things. So the exam can look different. It's completely fine to ask that you be in your regular clothes during the conversation part of the exam. If somebody comes in and says, change into a gown, it's all right to say, I'd prefer to talk to the health provider with my regular clothes on and then change afterwards, or you can go ahead and change. But don't be afraid to ask those things and to advocate for yourself and to stand up for what you need. You want a healthcare provider who will engage in shared decision making. So it shouldn't be somebody who's just telling you, you should take hormone therapy, you shouldn't do X, Y, or Z. You want somebody who can give you the information, who can empower you, and then you can have a conversation and engage in shared decision making to decide what is best for you. During annual exams are typically when we do cervical cancer screening or a pap smear. You can see this health professional is holding a model of the uterus or the womb, and that little brush is going into the model's vagina, and that's where those little tiny bristles collect cells from the cervix or the opening to the womb that are sent to a lab to look to see if there are any abnormalities of those cells. So that's cervical cancer screening. We often wait longer between them if we do human papillomavirus testing. And so we don't do pap smears routinely for screening every year anymore. If somebody's also doing HPV testing and if they've had all normal exams. So again, many caveats. So it's important to talk with your health professional. We also recommend bone density screening, typically starting at age 65, but earlier if somebody has risk factors for it. So you might discuss that. We typically recommend that someone consider starting to get mammograms if they're of average risk around the age of 40, but there are different guidelines that recommend different screening frequencies. As somebody who was diagnosed at age 42 with breast cancer after having had a completely normal mammogram at age 41, I am a proponent for annual mammograms if patients decide to get those starting at the age of 40. But I know there are different views on that. So I would encourage somebody to have a conversation with their healthcare provider about the frequency of breast cancer screening so that it's right for you. And then also colorectal cancer screening. We used to wait until 50 to start this, but the age has been moved even a little bit earlier. And so this is a picture of what it looks like when like a gastroenterologist is doing a colonoscopy. So you can see that they're looking at a screen where it's a picture of the inside of the intestines to screen for colorectal cancer. We know the incidence has been increasing in younger women, and so that screening is important too when you're of age. And then lab tests. Often your providers will recommend some lab tests, such as checking your hemoglobin A1C to check to see what your sugar level has been, maybe doing a lipid panel to see what your cholesterol is, a thyroid level. So all different labs that can be ordered that can tell us different things. And then certain labs are ordered based on certain symptoms. So now let's talk about treatment. There are a lot of options to treat a lot of different symptoms. The one that women usually want to know about the most or have the most questions about are the treatments for hot flashes and night sweats. We also call those vasomotor symptoms. So we want to take into account the symptoms that a woman is experiencing. If somebody comes in and says, I'm just struggling with brain fog, I'm going to think about it differently than somebody who comes in and says, I'm just struggling with dry skin, or I'm just struggling with painful intercourse due to vaginal dryness, or I'm having some hot flashes and night sweats and also these problems. And so that's where symptoms are important. Also the woman's experience, how bothersome are they? What is her health history? Does she have risk factors for certain things or things that might put her in increased risk for using some medications? What are your preferences, the preferences of the patient, and the comfort of the prescriber? There are many prescribers who don't feel comfortable prescribing hormone therapy. It's also important to ask that question, is pregnancy desired? Because if you are having even irregular periods, even if the ovary is not releasing an egg every month, you can still become pregnant until you've gone through menopause. So at least 1 year without any menstruation. And so if a woman does not desire pregnancy, it's important to consider contraception. Now, talking about menopause hormone therapy, it's our best treatment, or the treatment that has the best results as far as taking care of symptoms of hot flashes and night sweats. And you can see why. You can see if there's that menopause transition, you're getting that up and down and up and down. The hormone therapy helps to level that off. Now, it doesn't take it all the way up to levels like it used to be. So some women are like, okay, well, if these are the risks that come along with menopause, like brain health and all those different things, or body composition changes, if I take estrogen or if I take hormone therapy, do those risks go away or do I just delay those? No, because there are changes that happen. So it's not that simple. When we go through the menopause transition, our estrogen receptors change and things change, so that even if we have hormone replacement, it still is a window of vulnerability and opportunity where lifestyle is still just as important. But estrogen is very effective for hot flashes and night sweats for most women. We know that 73% of women choose to have no treatment. So you do not need to get treated for hot flashes. It is not something where every woman should get treated. There are hormonal therapies. There also are non-hormonal therapies approved for hot flashes. So those are medications that are typically used for other purposes, but that can sometimes help people with hot flashes too. We know that hormones, so I'm talking about like estrogen and progesterone, we know that hormone replacement helps more than just hot flashes. So it often will significantly decrease or take away hot flashes, but it also helps with blood sugar control. It helps with bone strength as well. For some people, it helps with sleep, especially if they're struggling with night sweats. There are questions about whether or not it helps with mood and brain fog. For some women it does, and for some women it doesn't. And then it can help women, especially if used locally, like a cream in the vagina, it can help with vaginal dryness. With estrogen, we usually typically use the lowest dose needed to help somebody with their symptoms. There was a giant study done that came out when I was in residency, I think over 20 years ago now, that showed that there were some increased risks with hormones. And so they were actually looking to see if it was useful, if we should be recommending it for heart health in women. And what they found is that estrogen or hormone therapy is not recommended for the prevention of other chronic diseases. Also, I think it's important to know that hormone therapy is kind of like an art and a science. And so it can take some time to find the right medication and the right dose. So it's something where if you go in and you see somebody and they start you on something and it's not working well, you need to go back and continue to engage in shared decision making so that you can get what works best for you. Also, it's important to note that guidelines have changed over time. Before the Women's Health Initiative, like 25 years ago, we recommended most every woman take hormone therapy. And now we recommend that it really needs to be on a case-by-case, individualized basis. Also, if a woman has a uterus and is on systemic estrogen, so not just vaginal estrogen, but they're taking estrogen where their whole body is seeing that hormone, they need a progesterone too. And that's because if we just take estrogen without progesterone and a woman has a uterus, it significantly increases the risk of uterine cancer. So that's why you sometimes hear people talk about estrogen, like if a woman has just had a hysterectomy, or if somebody has a uterus, then if we're prescribing estrogen systemically, we also need to be prescribing a progesterone to protect the uterus. Progesterone also is often taken at night because it helps some women with sleep, and it may help a little bit with hot flashes. But as I mentioned before, prescribing hormone therapy is a science and an art. And so you want somebody who's comfortable prescribing it, who can help go through your personal risks and benefits and all the different options, because hormone therapy is not just like prescribing some of our standard medications where we're like, oh, if somebody comes in for this, I give them this medication. It's much more complex. So one of the first decisions that's made is, does somebody need systemic hormone therapy where every cell in their body is going to see it, where we're going to be having levels of higher levels of estrogen throughout a woman's whole entire body? Or are we wanting something that is local, that's just systemic? For example, if somebody doesn't have hot flashes or night sweats, or maybe somebody is in their 70s and they come in and say, I'm just having problems with vaginal dryness, then often they'll be given a prescription for vaginal estrogen because it's really just those tissues that need the estrogen, and we're not wanting them to have high levels throughout their whole body. We also need to put your doctor, your health provider, is going to help determine if it needs to be cyclic. So if you're going to have a certain number of days where you take progesterone and then you're off of progesterone, so maybe you're still having bleeds because of how the hormones are being used, or can you be put on continuous hormones where you're taking estrogen and progesterone every single day? That depends on where you're at as far as the menopause transition. Are you still having periods, though they're irregular? So this is where there are so many different questions that your health provider needs to understand. Then there are a variety of different delivery methods. And so like the studies that were done years ago were on estrogen and progesterone that were given in oral form. So we have pills that can be taken. But what we've learned is that we think that transdermal or patches or like creams or things that get absorbed systemically through our skin, that those avoid the first pass metabolism in the liver. And so that we think that transdermally delivered estrogen doesn't have as high of a risk of blood clots as we get if somebody is using the pill form. So transdermal preparations are being used a lot now. So we have pills, we have patches, we have creams, we have mists, we have gels, we have rings that go in the vagina that release a little bit of estrogen every day, but such high levels that it is a systemic dose. We also have different vaginal inserts. So there are a variety of different delivery methods that can be right for different people for certain reasons. Now, you may have heard of bioidentical hormone therapy. And so a lot of people, when they think of bioidentical, they think of compounded or specially mixed up medications. But really, bioidentical just means that the chemical structure of the hormone is the same as structure as our hormones that our body naturally produces. And so that means bioidentical. And then there's non-bioidentical. So like the Prempro or the Premarin, which is short for like pregnant mare's urine, is not bioidentical to human estrogen, but we have a variety of bioidentical and non-bioidentical hormones. Now, some bioidentical hormones are compounded, like in a compounding pharmacy where they can mix up specific doses, often valuable for people who may have an allergy or something like that. But we know that there are many FDA, Food and Drug Administration approved bioidentical hormones. So you don't need to go to a compounding pharmacy to get bioidentical hormones. We have a variety of them. We have them oral, we have patches. So you can get bioidentical hormones now that are FDA approved, that are tested in all of those different safety layers. Whereas with compounding, there's some other risks. And so like our North American Menopause Society and the American College of OBGYNs say that there's some caution with compounding, with compounded hormones, and that they should be used in specific cases. But really, you want it to be shared decision-making based on a bleeding pattern, symptoms, experience, your medical history, your age, your lifestyle behaviors, your preference, whether or not you use hormone therapy. We know that the benefits seem like they outweigh the risks for many women who are having symptomatic, moderate to severe hot flashes. These are women who have no contraindications, which we'll go over. Women who are within 10 years of menopause, so they're either still, they're having irregular periods, and they haven't quite gone through that menopause transition, or they're within 10 years of that, of their last period. We also know that the benefits are likely to outweigh the risks for women who are younger than 60. When women get beyond 60, we are very reluctant to start hormone therapy because many of the risks go up. We start worrying about an increased risk of dementia, increased risk of some heart problems and stroke. We also only want to treat somebody if they desire treatment with hormones. It's not a fit for everyone. Now, we know that people who have a history of breast or uterine or ovarian cancer are at an increased risk. So we say they're typically not a candidate for hormone therapy. People who have had a heart attack, stroke, or a blood clot, people who have active liver disease, who are smoking, we have an increased risk. Women who are older than 60 or more than 10 years since menopause, they're at an increased risk where we often say they're probably not a good candidate. So I have a picture of myself walking behind my house because I am not a good candidate for hormone therapy. So as much as I highlight that it's a good option for many women and one that women should have the right to have a conversation about with a health provider who's knowledgeable and who feels comfortable prescribing if they want that, there are some people like myself who are not good candidates, and there are just some women who don't want to use hormone therapy, which is completely fine. Some contraindications include unexplained vaginal bleeding, estrogen-sensitive cancer history like mine, heart disease, heart attack, stroke, increased risk for blood clots, liver disease. So there are contraindications. So when you come in to see a health provider, they're looking at all of your history and all of these risks, and then they're looking at the risks and benefits of the hormone therapy. And we know that there are certain benefits that come from hormone therapy, such as a possible improved heart health that we've seen in certain circumstances if a woman is close to the menopause transition, or an improvement in bone strength. And then we know that we have an increased risk of some other things. And so that's where we're weighing all of those different things based on a woman's history, based on the hormone therapy that's being used or recommended, based on the actual type of estrogen or the type of progesterone. Is it bioidentical or is it not? Is it transdermal or is it being used systemically? So we have to look at all of those different things to be able to say, this is what I think is best in your situation. These are the risks associated with it. Does it have a slightly increased risk of a blood clot? Does it have a slightly increased risk of breast cancer? Often the risks have been found to be pretty minimal, but it's something where you need to be able to have that individualized conversation based on all of that knowledge. We also know that there are FDA approved drugs for hot flashes. such as hormone therapy. There's also Veoza, which is a neurokinin-3 receptor drug, and so it works a little bit different. It's not a hormone, but works on some of the receptors in the brain. There's also Brisdel, which is a selective serotonin reuptake inhibitor medication that's actually been found to help and is FDA approved for hot flashes. It's not hormonal. And then we also have many women who take medications or who are prescribed medications off label. So they don't have an official FDA approved indication for hot flashes, but we found that there are other SSRIs or selective serotonin reuptake inhibitors that were designed initially for depression. But when we give them to women, we found that it actually helps many with hot flashes. Or gabapentin is a nerve drug that helps some women. Clonidine, a blood pressure medication that helps some women with hot flashes. Oxybutynin, something that helps some people with urinary incontinence that can help with hot flashes too. So a variety of things. It's complex. Go see your health provider. I also want to talk briefly about genitourinary syndrome of menopause because I don't think it gets talked about often enough. But that vaginal dryness is very common for women as they go through the menopause transition. So we have options such as hyaluronic acid, and these are some over the counter. There's different suppositories that help with moisturizing. And then we also have lubricants that can be used with intercourse, vaginal intercourse, in order to make intercourse more comfortable. And there are a variety of different types. Uberlube is one of the ones that I will often recommend that postmenopausal women try. It's a silicone base, so it can be one that many women find beneficial. We also know that there are non-hormonal treatments and low-dose vaginal estrogen or vaginal DHEA, which is another hormone. There are oral medications. So there are other things that we can use to treat genitourinary syndrome of menopause. My message is if you're struggling with vaginal dryness, see a healthcare provider. The risks of using vaginal estrogen are extremely low. And there are many women who are not a good candidate for systemic hormone therapy. So once again, maybe it's somebody who's in their mid 70s, right? And so they might be a very good candidate though for vaginal estrogen. There are tablets, there are creams, there are inserts or rings, and it usually takes a few weeks to months to notice the full effect. But everyone's journey is unique. But regardless of how unique that journey is, healthy lifestyle behaviors are important for every woman during the menopause transition. Nourishing yourself is more important now than ever before. So full plate living. It's important across all different ages, but I would say when a woman is in their 40s or starts to enter that menopause transition, full plate living is extra, extra, extra valuable then and for the rest of your life. So nourishing yourself is more important now than ever before. Food is powerful medicine. It helps us to stay healthy, to get healthy. We know that as someone goes through the menopause transition, that decreased estrogen often leaves us hungrier for sweets. And so we want to make sure we're getting plenty of high fiber foods, that we're eating the rainbow. We also know that we don't want to avoid the sugar cycle where we're eating ultra processed foods where our blood sugar goes up and insulin goes up and then it comes crashing down. It's important that we try to maintain more stable blood glucose levels. So eat more food and less junk food, all things that Full Plate Living highlights. Enjoy fruits. Maybe you want some fruits with some nut butter, vegetables, whole grains, nuts, beans, seeds, salmon. I love salmon, so healthy fats, a variety of different healthy sources of foods. Fermented foods can be really beneficial for the gut bacteria, for the microbiome, for the trillions of bacteria that live in our intestines. So consider fermented foods, a serving or so a day. And I get asked a lot about soy products or dietary soy, so phytoestrogens or plant estrogens. And they can be a great source, like tofu can be a great source of some plant protein and plant estrogens. We've found that people who eat phytoestrogens typically have an increase in the anti-inflammatory microbiome species, which is what we want. We want anti-inflammation. So they typically have decreased inflammation, decreased blood glucose levels, and a decrease in visceral fat. Now, there are some studies showing that it may help women with some hot flashes and night sweats, and for other people, it doesn't help. But regardless, phytoestrogens have a variety of different health benefits. So I encourage people to eat one or, a serving or two of phytoestrogens every day. Also, during the menopause transition, joyful movement is more important now than ever. Movement, physical activity helps with brain fog that so many women experience. It also helps with the mood lability. It helps to level out somebody's mood more. We know that when somebody's physically active, their brain's releasing endorphins, and so you get that serotonin. It's a natural mood booster. It helps with motivation. It helps with focus and learning. It helps with the brain health. And so as a woman is going through that menopause transition, with that lower estrogen, we're thinking of brain vulnerability. And so we're thinking we want to be doing everything we can in order to optimize her brain health, to decrease her risk of dementia as she moves into her 70s, 80s, 90s, as she moves into older age. One of the areas that I think is most exciting recently has been the research around resistance training. So resistance training has so many benefits for women. Now, I don't want you to run to the gym if you're not doing resistance training and all of a sudden start lifting heavy weights and get injured. Don't do that. However, resistance training has benefits for mood, increased energy, quality of life, and a decreased risk of dementia. Also, you have many different options. You don't have to go to a gym, though you can go to a gym, but you can also use your body weight for some resistance. You can use elastic bands. I was using those just yesterday when I was working out. I had an elastic band that was around my legs and moving my knees in and out. So you can use that for resistance training. You can do some different types of water aerobics or use free weights or weight machines. There are many different options. It's important to do what you enjoy and you'll continue to do. And then also with resistance training, I'd encourage you to think about working with a trainer, with a physical therapist or a trainer, so that you make sure that you get an exercise regimen that is safe for you, because the last thing I want is for you to get injured, so that it's safe for you, but also where you're lifting weights in a way that's actually strengthening your muscles. As I mentioned before, one of the biggest things we notice during the menopause transition is the level of visceral fat increases and muscle and bone mass decreases. Now, we see this across the age, and we see it with men too. We see this kind of gradual progression with men. What happens with women is when women are in their 40s and the menopause hormonal roller coaster starts, is we see a significant change where we see women often gain a lot of extra visceral fat and a significant decrease in lean muscle mass. And so that's where resistance training, there's research showing that it's really, really beneficial. So I'd encourage you to consider looking into that. But do what you enjoy. Also, stress resilience is more important now than ever. So take time for yourself, engage in activities that help to decrease stress. We know that menopause symptoms are often stressful, and that stress can often make menopausal symptoms worse. You can get into that vicious cycle. So try to see what you can do in order to decrease that. Be compassionate with yourselves. Menopause is a struggle for many women, or it's a challenging time. And so I think we don't want to ignore that. We want to be compassionate and say, many women experience some struggles when they go through the menopause transition, and I am powerful and I have a lot of control over my experience by these healthy lifestyle behaviors, by being proactive and talking to my health provider. So today, as we wrap up, I encourage you to pause, whether you are in the menopause transition or not, whether you have passed menopause, whether you are looking forward to menopause in the future. What's good to know is that if we talk to many women prior to menopause, they'll often say that they're fearing it. So this isn't good, but we'll often hear that women are fearing it or that they're not looking forward to it. But when we talk to women who have actually gone through the menopause transition, they often view it very positively. So the women who have actually been through the transition often have a much a better picture, a more realistic understanding, and a much more positive view of the transition than society often leads us to believe. I encourage you to put all these different things in your toolbox, all the different things that Full Plate Living has taught you and has given you all the resources around healthy eating and movement and stress and sleep. Think of this as your toolbox in order to help you through the menopause transition. We know people who are physically active typically have fewer symptoms. We know that people who are eating a healthy diet that's rich in an abundance of healthy foods, they typically have less symptoms. Not always, so no self-blame or guilt if you're having symptoms, but know that it can often help. Restorative sleep is more important now than ever. We could talk about that for a whole hour. So restorative sleep is very important, but we'll have to talk about that another time. So make your bedroom a sanctuary for sleep. Beth Frady's from Harvard, who I just love dearly, says to keep it like a cave. So make sure your bedroom is dark, quiet, and then slightly cool, maybe around 65 or so degrees plus or minus, but keep it cool for better sleep. Also, eating a high fiber diet in the morning and getting morning sunlight has been found to help. And then last but not least, meaningful social connection is more important now than ever. If you're using social media, engage with that community. Meaningful social online engagement has been found to be beneficial for health. So don't just scroll through it, but actually find your communities. Your mindset is powerful. So how you think about menopause matters. To thrive as a female who's going through menopause requires an attitude that embraces the journey. So I want you to think about, what is your trajectory? What is it that you are aiming for as you age into your 60s, 70s, 80s, 90s? What is it that you want to be doing? Pause and slow down, as hard as that is in our culture, and think about what you need. What do you need today to help you thrive? Small, sustainable changes, small, you can do these little itty bitty steps, can improve your quality of life in the present. So they start helping right away, and they provide a foundation for a healthier future. And remember, pauses are only temporary. So push play, live intentionally, and thrive. So thank you so much for the opportunity to be here with you today. I know I ran a little bit over. I get so excited talking about menopause with women and men who are interested in learning more about it. But here is my personal email. So if we don't get to your questions, you can reach out directly to me. And this is the menopause book that I co-authored with my dear friends from Harvard, Dr. Beth Frades and Dr. Amy Commander. All the proceeds from the book benefit the nonprofit, not us as authors. So with that, I am happy to take questions.
So thank you so much, Dr. Tollefson. This was so informative, and I really appreciate the fact that you went over not just lifestyle options, but all of the medications that are out there, all of the hormone therapy options that are out there. And I know it was a lot. It really was a lot. We will send out a recording of this, and I encourage you to take the time to watch the replay, because some of the questions that we have through have already been answered. And so watch the replay. We will get to a few questions now. If you have more questions, you can reach out to Dr. Tollefson. I will also say, though, that if you have specific medication questions, she cannot answer those for you. Only your personal physician can do that. If you do not feel like you're getting the best help from your physician, you can also get a secondary option. You can talk to another physician and see what their answer might be. So let's go through some of these that are a little bit more generic. And here's an interesting one. Can menopause cause constipation? We have somebody who's really struggled with it since they've gone through menopause.
Yeah, so we know that estrogen definitely impacts the gut microbiome, and it can impact motility. So we know that there are estrogen receptors. So first of all, when a woman decreases the estrogen, what we see is a typical, not always, we see a typical increase in the inflammatory bacteria and a decrease in the anti-inflammatory bacteria. So that's where fiber is always important. However, fiber becomes extra important when women go through that menopause transition, because we really need to be nourishing those gut bacteria. Think of those gut bacteria as they're struggling when we go through menopause, and so we need to really nourish them. So, and also our thirst typically decreases. So making sure we're getting adequate fluid intake throughout the day, not just at certain times, but we're getting adequate fluid intake throughout the day. That we're eating a fiber-rich diet, and that if it's low, that you're gradually building your way up. But we do often see an increase in GI symptoms, but it's something too that don't just ignore it. So I would say, try checking in on fiber and eating an abundance of healthy foods and getting plenty of fluid intake. Know that some things can change with GI symptoms, but also then go in and talk to a provider if it still is bothering you.
Yeah, thank you for that. And I love that you included fermented foods in your list too. So not just fiber foods, but those fermented foods that also
definitely
introduce some bacteria in,
right,
and some fungi.
yes,
Gut microbiome needs.
Mm-hmm.
If you use vaginal estrogen, do you need progesterone, or is that only for systemic?
Yeah, that's a great question. So if somebody is using vaginal estrogen, there's different types of vaginal estrogen. So there are certain types of vaginal estrogen that are a high dose where you're going to get systemic levels. So I would say it depends. With vaginal estrogen, if there are high levels being used to treat hot flashes, or where you're getting those high of levels, you do need progesterone to protect the uterus if a woman has a uterus. However, if we're using vaginal estrogen mostly for vaginal dryness or for local impact, then that's where we don't need progesterone, because those levels don't get high enough to increase the risk of uterine cancer, at least looking at research that's a year out. A caveat is if you've gone through menopause and you have any bleeding, whether or not you're on hormones or spotting, you need to go in and be seen, because we want to rule out uterine cancer. Rarely is it, but it's something that we always want to keep in the back of our mind if someone has any bleeding after menopause.
Excellent. Thank you for that reminder. Because I'm not there yet, but I feel it would be very scary and confusing.
And rarely is it uterine cancer. I think it's only like 5 to 10%. So usually it's not, but it's just something you want to get checked out.
Okay, so here's another question. How is menopause defined in a woman without a uterus or and no period?
That's great. So a great question. We don't have the period to be able to follow, right? And so we often will see that women have similar symptoms. So if a woman has her ovaries left in place, then then the hormonal levels will typically continue to fluctuate, and her ovaries will release eggs. But the same thing will happen. Eventually, those eggs will run low in number, and then you're going to have the different kind of communication from the brain to the ovaries, trying to say really push those out. And so often, women will start to notice hot flashes and night sweats and mood changes and vaginal dryness. So we start to see many of the same symptoms, except that vaginal bleeding. That's where rarely are hormone levels useful, because really we look at symptoms. Those levels can fluctuate so much, but in a woman without a uterus, when we're looking to see has she gone through menopause, sometimes that's where hormone levels are helpful. But I'm not a fan of saliva testing for many women for hormones. There are certain cases, so not for everyone, but those levels, as you saw with that hormonal roller coaster, you can imagine that those levels might be high at one point in the day and low at the next point in the day. And so that's where there's so much variability that really we do much better when we talk with a woman about her symptoms and get all of her history. I would say maybe some people might think it'd be much easier to treat a lab value of I want this number, and so I'm going to treat up to that, but that's not the way it works with estrogen and progesterone. It really is so individualized.
Thank you for that. It is complicated. It is not very, very simple.
It is complicated.
So I think we need to be patient, not just with ourselves, but even our providers during this time. And it can be very frustrating for sure. Here's another question. I was told by my OBGYN that being in menopause resolves PCOS and endometriosis. Is this true?
Yeah, that's a great question. So with endometriosis, it's when cells that are typically within the uterus, when they're outside of the uterus. And so when most women would just have bleeding and shedding of the lining of the uterus, they'll have bleeding of those little implants that might be like on the ovaries or outside of the uterus. And so when somebody goes through menopause, when they're not having periods anymore, they're also not going to be having that monthly bleeding of that endometriosis of that tissue. And so they may still have that tissue, but they typically won't have that pain because it's not going to be stimulated and bleed every month. So that's where it's the cells don't necessarily disappear, but they're not being impacted by those high hormonal changes. Some people might say that resolves it. And then with polycystic ovary syndrome, we know that some of the risks associated with polycystic ovarian syndrome, that some of those risks continue even beyond menopause. But we typically see the polycystic ovaries when because of like the communication of some different types of hormones, including often testosterone, and how it's impacting the ovary. And so it's not necessarily that it disappears. It's just that you don't have those typical hormonal changes where we see symptoms directly from the PCOS. But I would say if somebody has a history of PCOS, it's really important for them to see their healthcare provider regularly, because they're at an increased risk for like type 2 diabetes and some different things. So you want to be really proactive with your health.
Regardless of whether or not you're in menopause.
For sure. Yes, exactly.
Excellent. So here's the perimenopause question. When is a woman in perimenopause, and what tests confirm it? Do you even need to take a test to confirm it?
Great question. So there's different groups that have tried to define it in different ways, but usually it's when a woman's period starts becoming irregular in length. But this is the tricky thing, is women's periods can be irregular in length from the time they have their very first period. PCOS, polycystic ovary syndrome, can cause irregular periods. But usually it's when, due to the hormonal changes, we start to see variability or irregularity in a woman's menstrual cycle length. There aren't really tests that we can do to tell if somebody is in perimenopause. Once again, because of those huge fluctuations, I guess if you caught it on a decrease, we would think, okay, they probably are having some fluctuations. But once again, the hormone levels don't really help us that much. What's more important is to be saying, what is your bleeding like? What is your age? What symptoms are you having? And then to be able to put all of that together. If a woman comes in and says, my periods are getting more irregular and I feel like I'm like just mood changes, I don't even know where they come from. I used to feel like I could be stable and something wouldn't make me very stressed. And now the littlest thing feels like it could throw me off the edge of the cliff. So you look at all of those things. So that's where I would say that there isn't really a though sometimes we do test for certain hormones, but it's more for like specifically premature ovarian failure. If somebody came in and said that they had stopped having periods and they were only 30, there are tests I would want to do because I would want to know, are they having premature ovarian failure? So anyway, so it's a little complicated, but for the most part, we do not test. For the most part, it's symptoms and changes in menstruation that we look for.
Excellent. Thank you for that. And I realize that we've gone a little bit over our time, and we do want to be mindful of your time. We will share a recording of the workshop as soon as this workshop is over. But we also, Dr. Tollefson has agreed to stay a little bit longer for questions. So we're going to go through a few more before we stop. Now, again, if you have a question, we haven't answered it, and it's not specific to a prescription or medication that you are on, you may also try emailing Dr. Tollefson, and she is happy to try and direct you in the right place to get an answer. Speaking about the weight gain from menopause and perimenopause, can you lose this weight, or are you stuck with it for the rest of your life?
Yeah. So great question. First of all, I think that's where we need self-compassion because it is hard and many people see that shift. I think so. It's not inevitable. So yes, you can lose weight. We know that weight is more complicated than just calories in, calories out. And I've seen some of the FullPlateLiving resources on weight, and I absolutely love them. I would say it aligns with the recommendations we see around perimenopause and menopause weight gain. So we want to think about, so like, I'm not as worried about subcutaneous fat or the fat that's right under the skin. It's more of that visceral fat that concerns me as far as health. And one of the things that I really think can be beneficial, and I know not all women have access to it, but is a body composition test. They're becoming like the ones where you kind of like hold the handles and you stand on a little platform and then it calculates that. If a woman's able to get her body composition and then follow that, I think that can be very motivating for women and also help them. So for example, after I went through chemotherapy and abrupt menopause, I was like, oh my gosh, I feel weaker. And even after that chemotherapy, I felt weaker. I hadn't really started weight training yet or engaging in that, but I could tell I was getting weaker and weaker and weaker after chemotherapy. And I noticed that my stomach was getting larger and larger and larger. And so body composition change is real. Now, what many women do is they start to notice my stomach is getting bigger, and so I'm going to cut back on my calories. And so often they end up in what's called low energy availability because they cut way back on calories, which is not what we want to be doing. We want to be nourishing yourself with a lot of those healthy foods, but watching caloric intake, eating a bunch of healthy, low processed foods, and then doing that resistance training. That's where it's so important. And I encourage women not to follow weight so much as their energy and their strength. So I want to know what women are doing as far as their strength. Are they getting stronger and stronger? My mom and I go and we actually do some resistance training. We try to do it every week together. But I want people to focus on gaining muscle and strength. And then usually we see with that a decrease in visceral fat, where it all works together. But once again, it needs to be like safe and appropriate aerobic activity and resistance training usually together. And then where we're eating adequate but not excessive protein, and adequate but not excessive calories. And Dr. Stacy Sims is a PhD who is an exercise physiologist who has a tremendous book, and I'm forgetting its name, but it's for menopausal women, peri and postmenopausal women athletes. That's great and really talks about that science too.
Excellent. Thank you for answering that so thoroughly. Okay, let's talk about 4 different kinds of tests and do a little comparison between a thermography versus mammography, and then regular DEXA scans versus the alternatives out there.
Yeah, great questions. So thermography, I don't feel like, and I know not everyone agrees, but I would say your major medical associations, your major experts in the field do not recommend thermography. They recommend mammography for following, for routine breast cancer screening. And then if somebody is at a high risk, sometimes we'll alternate that with like an MRI every 6 months, or if somebody has like a strong family history, or that maybe they're, but I don't recommend thermography. Maybe we'll get there eventually, but I would say that the science isn't there yet, and you're just, you're risking your health. So I do know that, that x-rays or mammograms come with a certain amount of risk, but I would say your major medical associations have all said that the benefits outweigh the risks. So I'm not a fan of thermography. I think the research just isn't there at this time. And that's what our kind of leaders who really dive into that say as well. How do I feel about regular DEXA scans? I think DEXA scans are great. They are more expensive. Sometimes they're covered by insurance, sometimes they're not. There are certain criteria. I think that DEXA scans are very important for women when we're checking bone density, and then to follow those. So for a woman who's 65 or who's younger and who has risk factors, definitely a DEXA scan. I've done a DEXA scan, and I will do my DEXA scans routinely so that I can monitor my bone mass. However, it's often more difficult to get them, or they're expensive, and we don't do them all the time. And so that's where some of these different, like the bod pod is one of, like, it looks kind of like an egg. I've tried all the different types. So you sit inside it and it measures, like in your swimsuit, and it measures your body composition. But there's ones now, like even the place where I exercise down the street, and they have one at the cancer center, physical therapist, where you stand on them and you hold onto these two. They look like ski poles, and it does body composition. And so those are often less expensive for people to get access to. And I think they can be really motivating to see what your body composition is doing, where we focus on strength, where we focus on energy. As you do resistance training and exercise, you increase the mitochondria, the powerhouse of the cells. And we know as you go through menopause, we typically see a decrease in the mitochondria, and the mitochondria that we have don't work as well. And so that's where you start getting fatigue. And so that's where we really, like the science, I'm not a natural, just go to the gym person. I don't run marathons like Dr. Amy Commander and Dr. Frates, but where the science is really showing us how important physical activity is for the peri and postmenopausal woman.
Excellent. And let's go ahead and take one more question. Again, Dr. Tollefson, if you don't mind putting your email address in the chat for anybody else, or just pulling up that last slide.
Okay.
In fact, I'm going to just pull the slides up one more time and see if it's on.
Go back one. Let's see if we can go back.
Yeah, there we go. So that if anybody else has a question that we haven't answered, and again, it's not prescriptive to a medication that you're taking, you can feel free to email Dr. Tollefson. One last question. Menopause does cause a loss of libido. I know that we spoke about that in the workshop. What can be done about it? Are there options for women in perimenopause? And what about women that are over 60 and have already passed through menopause?
Oh, so we can do a whole talk on sexual health, because this can be a very long answer, but it's a very good question. I think it's one of the things that we don't talk about enough. Many women experience a decrease in libido for many reasons during the menopause transition. First of all, if somebody does have that vaginal dryness, and if vaginal intercourse and that sort of relation somebody is having, if it's uncomfortable, of course, that's natural to have a decrease in libido if somebody is worried about it being painful. Also, we see testosterone levels decrease, and often with that, we'll see a decrease in libido. Often women are more stressed and they're not sleeping well. And as a woman does not sleep well and is more stressed and cortisol increases, we often will see a decrease in libido. So there's a lot of different things happening. We also know women are under a lot of stress, often in that perimenopause transition, often taking care of kids and adults, the sandwich generation. And so there's so many things going on. So I think, first of all, it's self-compassion. You are not alone. There's nothing wrong with you or wrong with that relationship. But no, this is again where it's important to talk to someone who is educated in this. The two areas that I say are kind of the maybe the trickiest for many physicians to feel comfortable talking about are menopause and sexual health. And with both of those, they're long conversations. Often your doctors and your health professionals weren't trained to have those conversations. And so they just kind of avoid them, like, it makes me uncomfortable. I'm not sure that I can help. But there are two areas where it is so important to find a provider who can support you with that. In the Paving book, the chapter on social connection, I dive into libido in more depth, and I'd be happy to to come back and talk, but it's a kind of a long answer, but there's a lot of things looking at other ways to be intimate, hugging, snuggling, realizing that often physical intimacy changes with age. And so it's somebody bothered by it or not. There are certain medications that we can use, sometimes off label. So sometimes it is hormones. So a lot of different things, but sexual health is important. I encourage women to not feel embarrassed talking about it. Most gynecologists have expertise in it, or if you call a gynecology office where there's a lot of providers, usually you can say, is there a certain doctor in the group who does more with sexual health than others? And you can do the same thing with hormones. Is there a provider in your office who really specializes in menopause or in hormone therapy or sexual health? And often they can connect you with someone too. But great question.
Yeah, thank you so much for those tips. And if you have enjoyed this workshop as much as I have, please drop a note in the chat to Dr. Tollefson. Again, thank you for taking the time. This was such a thorough workshop. If you want to learn more, I'm assuming that you do talk a little bit about sexual health in the PEGVing book. And
For
so
sure.
if you would like to, you can also purchase the book and learn more about that. As far as the dietary changes, the lifestyle options that we have, I encourage you to go through your FullPlateLiving resources. The core program covers a lot, and then you can go into the weight loss course afterwards. You can also do the diabetes course that go a little bit deeper into stress management, into exercise, and then some of those other pillars of lifestyle medicine besides just nutrition, even though nutrition does make a big impact. Again, thank you for being here with us, and I hope that you all have a wonderful rest of your day.
Thank you so much. It was a joy spending time with you and your guests. Take care. Bye-bye.